And as Alex is getting ready, I just want to remind that all of our public comments should be limited to 5 minutes, and there will be a timer on the screen to help you with that. And when you introduce yourself, please also declare if you have any conflicts of interests. So, Alex, go ahead.
Hi, can you hear me okay?
Yes, we can.
Excellent. Thank you for letting me speak, and thank you for a great presentation today. My name is Alex Krell. I'm an epidemiologist at the nonprofit research institute called RTI International, and I've been conducting research related to safe consumption sites for the past 12 years and syringe services programs for the last 27 years. You may know some of my work from the evaluation that we're currently doing on the unsanctioned safe consumption site in the U.S. Over the last 6 years. I was really impressed by the ICER team and their process for gathering information to learn about the safe consumption sites. In particular, I thought it was great they conducted all these qualitative interviews with a number of people working at safe consumption sites and people who use or inject drugs as well. And they include information that they learned from those in the report. And I thought that made the value of the report, it really added to the value of the report. I kept, and even as I've read it a few times, and even as I was listening today, I keep kind of wondering about this whole piece about why is this comparing SCS plus SSP to SSP only? Like it just doesn't, it doesn't make sense to me. I mean, partially it precludes analysis of some of the outcomes that are important because there wasn't sort of enough outcome data on these kinds of things, but really there's no data out there. I mean, I'm not aware of any other research reports or any research that's been done out there that's actually compared SSP plus SCS to SSP. And so it's in that sense, it's not really a review of any of that literature because there sort of is none of that literature. And I'm also sort of not sure why, like theoretically, why you would even do it. And some of that came up in the discussion after the clinical data in terms of what happens and where can we expect there to be benefits of these services. And while it's not as simple as this, most of the research is sort of assuming that the benefits of an SCS, of a safe consumption site, are mostly met and happening at the SCS, whereas most of the benefits of an SSP or a syringe services program are generally thought to be outside of the SSP. And so in that way, they're kind of very different. Now, I actually think that that's not true. It's just, I'm saying the data and most of the research that's been done has sort of classified these benefits as happening either at the site or outside of the site, depending on which of these interventions we're talking about. But nonetheless, I don't think any service providers or I actually don't think any policymakers out there are actually thinking, oh, okay, should we add, an SCS to the SCSP, or as somebody asked about earlier, like, do you want to make a decision about whether to add, to do one or the other? Like, I don't think that's where the policy discussions are at. And I think the data, we just don't have data on this. And I almost wonder if you want to compare SCS to plus something to non-SCS, I think like housing would be great. I mean, like why pick SSP? Housing plus SCS versus just SCS, for example. Hey, okay, I'm kind of interested in that. Or MAT plus SCS versus just MAT. But I don't understand the purpose of just looking at this and the whole sort of framing of the report as being SSP plus SCS versus SSP. So I'm curious about that particular piece. I think the last piece that I'm also a bit disappointed in is just, any intervention is only useful if people are actually interested in and have the access to the intervention. And I felt like it was a bit of a failure to not include data on the willingness of people who use drugs to actually use these sites. I think that, there is such papers on that. We have papers on that in the US. The data exists. And people are, it's sort of everywhere you go, it's somewhere in the 84 to 86% of people injecting drugs would go to these. However, in the policy environment, and if you look, lots of people think that, you hear this all the time to policymakers, that, hey, people won't use these sites if we make them available. And so that's a big sort of glaring gap between where the policy environment is, and there actually is data on this that you could have reviewed and actually included in there. So I think that's a piece that could be, that shouldn't be ignored as well in that. But in spite of these limitations, I really like this report. I'm very impressed by it. And I think that serves a great purpose. Thank you so much for letting me speak today.
Thank you very much for your comments, Alex. Do we have any comments from members of the ICER team?
I'll try to take both of them. Alex, thank you very much for your comments and the critique and really the contributions in the way we thought about this report early on. I think we all very much appreciate that. I think on the point of acceptability or adoption or use of CIFs, you're right, the report does not explore that particular topic. We could have included, and I think I'd let you want the CEPAC members to know that many Canadian CIFs, as well as the ones in Australia that we've reviewed evaluation reports, do publish, counts and access and the number of people that are using the site, the CIFs, and without, I have a high confidence in my ability to say, like, these facilities are used, right? When they are open, they are used by clients. So I don't want anybody on the CEPAC to walk away from this idea that the interventions that have been studied were somehow had low utilization. Like that's not true. On the point about the CIF versus the SSP, I mean, this was, it is ICER's approach to have a comparative effectiveness or a comparative approach. So we were using that framework as we came into this case. And, there was a background SSP in play in the communities that we were studying, right? So when a CIF was added, say in Sydney or possibly in Vancouver, if we go far back to 2003, a syringe service program or a syringe exchange program was in play in that community at that time. And so that's how we thought about it, right? Which is there is this incremental value or incremental benefit that's accrued by the community for adding a CIF. Yes, there are limitations to it, and we don't have head-to-head comparisons, but that was our thinking. I'd share that with the CEPAC members. David, if you have anything to add to that, or others. Okay.
David, do you have anything further?
No.
Okay. Matt, did you have a comment?
Yeah, I just wanted to go back to something Alex said. It kind of seems so silly that we have these legal sanction place where people can come and consume their substances and stay safe, but the real harm and trauma and things that keep them in that lifestyle, we're not dealing with that. We're telling them, go get your own drugs, go engage in survival sex work, go sell drugs, go commit crime, and then you can come here and we can make sure you're alive, right? And I know for me, harm reduction saved my life, but a safe supply of drugs would have given me a life. It wouldn't have given me a criminal record. I may have not have got Hep C. So, I think we really have to broaden our scope or we're going to miss a huge population of the people, because as people mentioned, if it's not accessible, if people don't feel safe, and if they don't trust the organization, they're not going to come. So when you have all professionals and academics and police officers working at a site, you're not going to get the population that needs it the most. So I just wanted to throw that out there. Thanks,
Matt, very much. So now we'll transition to David Rind, who is going to read some comments and editorial comments, I guess we should say, from a Boston Globe article. David?
Thanks, Rob. This gets at the fact that we had a lot of trouble getting input from people who weren't necessarily in favor of CIFs. And there was an article about our evidence report published in the Boston Globe. And we took some comments from there. And then actually there's going to be one last comment that arrived in our mail this morning from Vermont. The first one, I'm just going to read. One of my main concerns about safe injection sites is that they need to have a programming component to address the substance use disorder. FRIAR states that those who avail themselves of these sites are more willing to go into treatment and that the crime rate in the area is not impacted. I think the article would have been more complete with some statistics on this instead of a casual mention. The closest thing that we have to an injection site in Boston is Mass and Cass. My sense from speaking to business owners and others who work in that area is that the crime rate has been impacted significantly. The idea is worth considering, but we need more information. This article missed an opportunity to provide it. Realize that's a comment about the article to some degree and not about the ICER report entirely. Another comment, it could save money and lives, but officials and politicians who approve these sites are not opening them a few blocks down the street from where they, their families and children reside. Next comment. Next slide. What does running a supervised injection site cost? There is no such thing as safe injection of street drugs. And what services could be purchased for that same price to support people trying to get clean or stay clean? The site would need to be 24 hours, 365, would need round-the-clock medical staff, custodial staff, and security staff. Rent and insurance, including insurance for when someone dies or is damaged despite medical care, or when one customer injures another customer or a staff member. How many rehab beds could be had for the same price? Because when someone hits their low and is willing to go for treatment, there usually is not a bed for them. Let's fund that first. No, no, no. This is a horrible idea. People with drug dependency and abuse issues need help to get clean, not a safe, clean place to use. This doesn't promote treatment for these issues. It promotes a comfortable place to use. Why would anyone want to stop using if they were made to feel comfortable and safe while using? Ridiculous. And then next slide. And again, this is from this morning we received this. The Vermont Opioid Coordinating Council, in conjunction with the Vermont Department of Health, did a CIF literature review in 2018, which came to a different conclusion than yours. For example, when you discuss the 35% overdose mortality reduction with 0.25 miles of insight during the first year, you fail to mention the substantial increase in the police presence in the same area, and they sent their report. And that was the series of comments we received. Thank you.
Thanks, David. Do we have any comments from the ICER team or our CEPAC panelists? Jason, go ahead.
I just wanted to first say thank you to David and ICER for soliciting that and working so hard to get this perspective integrated. I guess I would just love to hear from the panelists about, especially people who support SIFs, about, I would love to hear your response to that criticism.
I'll chime in here briefly. So we had a number of community consultations for the 4 originally funded SISs that Health Canada had given the exemption 56 for. And exemption 56 is just to give you a green light to set up an SIS here in Canada. And to tell you the truth, you know, we had a number of experts at the community consultations, and there wasn't a lot of backlash. We were expecting a lot of flack, but once people heard the evidence from physicians, from people like Matt and I, lived experience, you know, even people that were on the fence and some who were on the other side of the fence started to reason. They go, "Wow, okay, maybe that makes sense. Maybe they weren't one overnight." But I see some of these people later on and they say, you know what, that wasn't such a bad idea what you guys were getting at. You know, once people hear the evidence, and not necessarily statistics, but sometimes if they just hear it from somebody's mouth and their own experience, what they went through and how they got better or how they got well or how they stayed out of jail, this has an impact on people.
Thanks, Peter. Scott Hadlin has a comment.
Yeah, I just want to stop and reflect that that those comments really do, you know, as Matt had highlighted so thoughtfully earlier on, reflect the stigma that surrounds people who use substances. That you know, I think you know, there are a lot of comments that are written underneath articles, and They're not always positive. I think you did a really nice job of capturing, I think, what are some of the common arguments that you do hear from people. And I will say again, I lived in 8 years in Boston, in the neighborhood right by Boston Medical Center, which is really where the bulk of our addiction services are provided in the city. And I saw a lot of that stigma firsthand, and I heard a lot of these reflections. And stigma aside, these are real concerns of people. And so I really do appreciate what Peter said, because when you actually dive into the data and you look at the evidence, and you hear the stories of people who use substances, the reality on the ground is very different. A couple of counterpoints that I would offer, first of all, to this point of, why aren't we investing this money in a different way? Certainly there are a lot of different ways that we can invest our public health money. This doesn't have to be an either or situation. This can be a this and that situation where we're throwing multiple interventions and solutions at what is, one of the biggest public health crises of our time. And the other point that I would argue is just, on the very specifics of why not invest these in detox beds. Well, actually, the data do not support that detox beds actually help people to get into treatment. Actually, you kicked the can down the road a little bit. You actually, you get someone into detox. And first of all, that's not an evidence-based intervention. And second of all, you kick the can down the road because you still don't have space for people after they finish in detox. They need a place to go after that. And so we really need to be investing in the entire continuity of care, the entire continuum. And so I don't think this is a situation where we should be choosing SIFs versus something else. I think we need to be building on our continuum of care by adding SIFs to that. I also do want to caution that, in response to the Vermont comment, the comment originating from Vermont that at the same time in Vancouver, police presence went up in the area. I just want to, correct the misinterpretation that increasing police presence in an area results in less drug use and fewer overdoses, because it doesn't. There is actually, to the contrary, lots of evidence to suggest that criminalization of substance use actually leads to more overdoses. So I want to correct that and just highlight that that's, what you observed in Vancouver in that area at that time with the increased police presence is, in my opinion, purely correlational. I mean, as an example, the number of really fancy restaurants in that same neighborhood went up over the same period. And I don't think that actually is what caused overdoses to go down in the area. So I just want to highlight the stigma, really encourage us to look at the entire continuum of care and a SIP's place in it. And then third of all, to just to correct that misinformation around police presence.
Thanks very much, Scott, for that comment. The next comment is from Alexis Roth.
Hi, yeah, thank you. Just to sort of contribute more to something that Scott was saying, is police presence also is associated with an increase in infectious disease acquisition. And so if we think about that within potential benefits or the potential cost savings, then increases in infectious disease are also highly costly. The other thing I wanted to sort of talk about that was mentioned in the report was the importance of context. And so I would wonder, in using insight as one of the model that we're drawing from, recognizing that that's sort of the Cadillac model, but that there are other models that are much less costly that are equally effective in preventing overdose deaths, which is the main outcome of a safer consumption site. I guess I would wonder about how that would impact the cost benefits, assuming that there are less expensive models that are equally effective. And then the other contextual thing I'd like to highlight is, you talked about changes in drug market over the last 10 years, the introduction of fentanyl and how it's more lethal. It's also got a shorter half-life, so we know folks are using more frequently to avoid painful withdrawal. And as such, there's a greater likelihood not only of overdose deaths, but also, again, syringe sharing in places where syringe coverage isn't sufficient, which can lead to increases in HIV, which we see in the US outbreaks, right? That we've got 5, 6 outbreaks happening, most of which are happening in cities where there are longstanding SSPs. So I guess those are my two questions, right? So how does the fact that we're drawing from the highest cost model as our exemplar, and also that the drug market has changed, at least in some places like along the East Coast, and how that might change or add to the interpretation of the data?
Thanks very much, Alexis. So at this point, we need to prepare to move to the voting part of our program. And I'm going to turn it over to Steve to do that. But I just want to say, I know there's probably other folks who want to chime in on some of these important issues. There will be ample time in the policy roundtable to do that. And I just want to thank all of you for your comments and thoughtful input. So Steve, take it away.
Thank you. That was a great conversation, and it did tee up, as you said, some of the issues we'll dive back into in the policy roundtable. So we're going to want to come back after a short break to talk about the evidence again and to have the CEPAC walk through its votes. Given that we're a little bit behind schedule, why don't we just go ahead and take 10 minutes, but that means we will reconvene at 2:20. I think we'll be able to move through the votes expeditiously enough to make that work. So we've got a 10-minute break, but we'll be starting right on the dot at 2:20.